Ready to Oxygen Therapy and Critical Care, the case-based series. Before we begin, a few housekeeping notes. We will be using the chat function for question and answer. The button to use the chat should be at the bottom of your screen. If you're on your phone, you'll see at the bottom of your phone screen, there are 3 dots. Click on that and you'll see the option to go to the chat. Please send all questions through the chat and feel free to introduce yourself. If you're having any IT or tech issues, send us a message through the chat and we would be pleased to help you. And this session is being recorded and your attendance is consent to being recorded, so thank you. Next slide. So thank you for joining today. We are on session 10, Obstetric Considerations for Oxygen and Critical Care. The date is March 2nd, 2022. And as usual, we have the following list of educators with us to take us through the content. Today's session will actually be led by Dr. Joseph, and he will be accompanied by Liberata, Dr. Venuste, and Dr. Apollinaire. Dr. Francois may join us. He's having some network difficulties, but we'll definitely welcome him if he's able to make it into the meeting. And so with that, I'll hand it over to Dr. Joseph.
So thank you again. Thank you everyone who is attending this session, presentations. Of course, let's thank again our partners for their support to get everything in the plan, especially Stanford Anesthesia Division of Global Health Equity, Assist International, and Project ECO. So, of course, remember that at the end of every session, everyone will get a certificate of completion of our session attended. And the topic of today, as said before, is obstetric consideration for oxygen and critical care. And as usual, we're starting by case. Next stage. So our case today, of course, is a pregnant woman of 28 years old woman with a gestational age of 29 weeks. And she presents you with fatigue and short of breath. So those symptoms started 2 days ago with a stuffy nose, rhinorrhea, and feeling of fever. I thought she has not checked her own temperature. So her pregnancy has been uncomplicated, but now she's concerned that she doesn't feel much fetal movement for the last day. So she's a teacher and she's not aware of any exposure to COVID-19, but she doesn't interact with child daily. So as obstetric history, she has 2 previous uncomplicated term delivery, and in the medical history having hypothyroidism, and he's on levothyroxine. The rest is unremarkable. So at the end of this presentation, everyone will be able to manage these pregnant women in his settings. So let's start and let's invite our next slide, please. Okay, so let's go back in the literature in the WHO, where they report that the maternal mortality is very unacceptably high. It means in like 4 years ago, in 2017, approximately 810 women died from the preventable cause related to pregnancy and childbirth. And the majority of maternal death occurred in low middle income countries, where 94% of all maternal deaths occurred in those settings. Of course, maternal mortality is higher for adolescents again. This is a report from WHO, where adolescents are facing higher risk of complication and death as a result of pregnancy than other women. Of course, also inequity in access to quality health service with the skilled care before and during and after childbirth. It can save life of women and the newborns. So those are updated from WHO. And then we got more. And let's see our objectives and presenters. Next slide, please. So those are our learning objectives, and let's see how we have a partition by each presenter. Next slide. So in our objectives, so Madame Levelata will talk especially physiologic change during pregnancy, and she will help us to describe how a physiologic change of pregnancy after can affect maternal well-being, and how physiologic change of pregnancy can affect the disease presentations. Of course, how does a change in arterial blood gases can occur during pregnancy. And Savio, if he came, he'll talk about the goal of oxygen therapy in the pregnant, and he will help us to understand and to recognize and describe the sign of maternal distress, and then recognize and describe the sign of fetal distress. And then Dr. Venus to talk about multidisciplinary team member, really which is required to manage a critically ill pregnant patient. Of course, to describe the unique constellation during gestation of pregnant women, then how to use a cognitive aid for obstetrical emergencies, and then we will end by to be able to assess COVID protocol for obstetric patients. So by now, let's invite Madame Liberata to start with those physiological change during pregnancy. So let's welcome Dr. Madame Liberata for his talk. Thank you.
Thank you, Dr. Joseph, for a nice introduction. I wish to go to the next slide, please.
Here you are, Libela.
It's not moving. It's not moving to me. Maybe I can use the slides those I've downloaded earlier. So for physiologic change during pregnancy, it's good for us clinicians to be aware of them, for us to anticipate some complications which may happen during pregnancy, especially for a critically sick pregnant woman. Of course, pregnancy is associated with physiological changes, and we should know them. And those ones can be anatomical, physiological, or biochemical. And those changes will allow a fetal development, a fetal protection, and preparation for labor for this woman, and compensation for the new demands which may happen during delivery. Next. It's moving, it's okay. I'll keep using mine. So there are some factors which affect the mother's ability to adapt with those new demands of pregnancy. And the first one is the maternal age. As you've seen from WHO reports, it shows well that young girls were very, they had high risk for maternal mortality because of their age. Also, an advanced age can expose to the mother to be unable to cope with those demands during pregnancy. This includes multiple gestations or existing of any other health conditions like diabetes or cardiac failure during pregnancy. Also, there is a factor which relates to the genes, genetic factor. Next. So those are the factors which may affect the inability of a woman to cope with those new demands during pregnancy. So first, let's look at the heart and see what will be changing. When we look at cardiovascular during pregnancy, the blood volume will increase by 10%. And of course, with the increase of demand of perfusion, there will be an increase in blood volume by 10% compared to the non-pregnant women. And there will be expansion of plasma volume, which will allow adequate perfusion of vital organs. And the total body water will also increase by the end of the gestation. Of course, if the fluid increases, there will be like hemodylation, which will decrease the concentration of albumin. And I'm very sure that most of us here have seen edema during pregnancy, which might be caused by this decrease of albumin. And of course, when albumin is decreased, there will be decrease of oncotic pressure, which will lead to the edema that we see among our pregnant women. In a blue color down, it's written that when there is an underlying condition that is very sensitive to increased blood volume or heart rate, this condition may decompensate too much during pregnancy. This is why when you go in the previous slides, they say that one of factor which may make a pregnant woman to be unable to cope with this new demand includes the underlying condition. If the underlying condition is there and it is very sensitive to increased blood volume, and yet, as in normal physiology or cardiovascular, the blood volume should be increased. So if the condition is there, the situation will be aggravated. Next. Hemodynamically, the blood pressure of this pregnant woman will drop. And this is secondary to hormones, especially progesterone, where the effect of progesterone on blood vessels, it dilates. It causes vasodilation, and this vasodilation will end up by causing the drop of blood pressure. Heart rate will increase, of course, to allow to increase the cardiac output and increase the stroke volume. And of course, as you know, if the heart rate increases and the stroke volume increases, definitely the cardiac output will increase, which will help a pregnant woman to perfuse vital organs. In the small table there, it's written that pregnancy normally it's considered as a most amazing, joyful experience for women. But when the blood pressure drops too much, it becomes very difficult to enjoy it. Next. On the respiratory system, there will be an increase in tidal volume. It means the volume on inhalation and exhalation will be increased, and this will be done to respond to the increase of oxygen consumption for pregnant women. Of course, if the tidal volume increases, the minute volume also will be increased, and there will be a decrease in functional residual capacity. And of course, there will be mild respiratory alkalosis. We will see in deep in the next slides where we'll be analyzing a little bit the ABG of a pregnant woman. And this respiratory alkalosis will happen because a pregnant woman is hyperventilating to respond to the increase of tidal volume, which should happen during pregnancy. So when we see like a critically sick pregnant woman, if there is a need for intubation, considering the changes, the physiologic changes during pregnancy, there will be difficult intubation. This is why we are advised to always prepare different sizes of ATT tubes, so that whenever it's difficult, we can try different sizes of those tubes. We need to pre-oxygenate. Remember, this patient has an increase of oxygen consumption, and as there is a decrease of functional residual capacity, we need to pre-oxygenate to avoid a rapid desaturation for this pregnant woman. We will also utilize higher airway pressures due to lung compliance, which decreases during pregnancy. Next. On the renal system, there will be hormonal effects, and there will be the increased metabolic load of fetus, and there will be obstruction of ureters due to enlarged uterus, which is holding a fetus. It's what we call mechanical obstruction, or due to urethral compression, which is being caused by that enlarged uterus. This is about renal system. Next. On GIT system, as the uterus grows, there will be compression on the stomach, and of course, if the stomach is compressed, it's pushed a little bit high, and this will expose a pregnant woman to gastric acidity and reflux. The patient will be complaining to have like acid content in the esophagus, which is like it's like a burning sensation for this pregnant woman, because there is like a reflux from the stomach, which is compressed by enlarged uterus. So of course, if we are to intubate these patients, we have to consider that because of that stomach which is pushed up, there might be a risk for aspiration for this pregnant woman. So we need to be conscious much. Next. This is an ABG of a pregnant woman compared to the ABG of a non-pregnant woman. When we are analyzing an ABG, remember, we look at the pH, we look at the PaO2, we look at the pressure of carbon dioxide in the blood, and we look at the bicarbonate. So you remember, with the need of increased tidal volume among pregnant women, if you compare the non-pregnant women to the woman who is pregnant the first trimester, you find, if you look at a pH, normally for a non-pregnant one, we have 735 to 745 for the pH. But when you look at the pregnant woman for the first trimester, you find that the pH is increased from and it's between 742 to 746. And you remember, when the pH is above 745, we are on the side of alkalosis, which shows that this patient is in alkalotic state, and we are going to see if it is respiratory, as we've seen from previous slides. Look at the PaCO2, the pressure of carbon dioxide. For normal person, should be between 35 to 45. But this pregnant woman, because of hyperventilation, it's found between 28 to 29. So it has decreased because the patient is a pregnant woman is hyperventilating. It means she's washing out much CO2. And you look at the bicarbonate, you find it normal. A non-pregnant woman is between 22 to 26. When you look at the first trimester pregnant woman, you find it at 18 millimoles per liter, which means it has decreased. It has decreased means bicarbonate is on the side of acidotic, which means this bicarb is compensating to the side of respiratory, which is in respiratory alkalosis. Remember, those respiratory system and the urinary system are a buffer system. They compensate each other. Next slide, please. Those are the differential diagnosis which can be thought about when we receive a pregnant woman. When we look at on head, eyes, ears, neck, and throat, we can have angioedema, anaphylaxis, pharyngeal infections, deep neck infections on foreign body or neck trauma. When you go to chest wall of a pregnant woman, rib fractures, flared chest, this is when the accident happens, or any physical trauma. On pulmonary, we can have a COPD, asthma, pulmonary embolism, pneumothorax, and etc. When we go to cardiac, we can have an acute coronary disease, heart failure, flash pulmonary edema, cardiomyopathy, arrhythmia. Those are the differential diagnoses that we can find for different systems when we see a pregnant woman. Neurologically, a pregnant woman can have a stroke or any neuromuscular disease. Toxic, she can be poisoned by organophosphate or salicylate or carbon monoxide. Those are the things that we should think about for different systems when we see a pregnant woman. Next. So those are the questions just to review what we have discussed in the last few minutes. And the first questions are asked. You will use the chat box quickly to get response. First question, pregnant patients have an increase in their tidal volumes. We have seen this as a normal change physiologically, and the respiratory rate through normal physiological change of a pregnancy. So what changes would you expect to see on arterial blood gas? I wish to hear from you, please. Which changes if a patient is having, wait, just a minute. Patient is having an increased, go to previous slide, please. Dr. Joseph, do you allow me to hear from response from participants, or we leave them to respond in chat for sake of saving time?
We can hear some of them, if they are, yeah.
Yeah, just yes, I will be giving them 2 minutes for each question. 2 minutes is not too much. 2 minutes, fine. Dear friends, please. First question, which change do we expect to have on an APG? Hirwa Olivier, can you respond to us? If you had the rapid breathing, the high increased respiratory rate, and increased the tidal volume, what do we expect to have on arterial gas, arterial blood gas? Jacqueline? No response? Yes, quickly, no remember response. We have, let me try. I'm just, I wish also to know if we are with people in class. Gasengaire Olive, how are you? Olive, just hi, say hi.
Okay, so just let's give them a time, and they maybe get different response in the chat, and then we go together.
Okay, fine. Eh? So the second question he asks is, respiratory physiologic changes include the following, except. It means from the list you will choose one which is not correct according to the respiratory physiologic changes for a pregnant woman. Next slide. So sub-question, next slide, please. It's another question. Wait. Good. Yes. Each of the following are also physiologic changes during pregnancy, except this is on cardiovascular system now. First, increased cardiac output. B, dilutional anemia. C, spine hypertension syndrome. And D, increased blood pressure. Let me check. There is someone in chat who has responded. Oh, no, it's just Olive Gasengaire was responding to me that she's around. Yes, thank you, Olive, for saying hi. The next will be to give us responses in the chat. Joseph, thank you so much. But maybe I will be following answers from here, then I will respond.
So thank you very much, Madam Libelata, for this nice presentation on those or physiologic change during pregnancy. So, of course, this tells us as a clinician, if you are managing a pregnant patient, just let's remember all those physiologic change and manage our patient accordingly. So remember our case. Next slide, please. Okay. So remember, initially you had a patient, pregnant. She was a 20 years old female who came in respiratory distress. He came in with short of breath. So, and now, after a physical exam, the patient is found to be having contraction, but they are irregular and they occurred approximately every 8 to 12 minutes. So the cervix is closed. So those initial vitals, temperatures at 38.9, heart rate 115, BP 140/75, respiratory rate of 18, and SpO2 of 91% on room air. So the patient fetal heart rate. So in our settings, most of them are saying be safe, 125. So we will manage this patient according to those physiologic change and other issues. So now let's go on the next slide to see what can we do on those respiratory distress during pregnancy. So here we will list the goals of oxygen therapy in pregnancy, and then we list sign of maternal distress, and then sign of fetal distress. So this is the fetal maternal distress presentation. Next slide. So let's talk on oxygen saturation in pregnancy. So the recommended SpO2 in the pregnancy is no more above 95%. This is on the room air. This is a normal recommended SpO2. And in the non-pregnant patients, especially with COVID-19, the recommended oxygen is above 92. Remember the previous presentation. And the maternal SpO2 is the measured of oxygen and with ambulation or exertion. So really, if I'm measuring a pregnant patient of oxygen or ambulation or exertion, this really it will be very accuracy. Of course, every patient with SpO2 below 19 means a pregnant patient in our case. Remember to admit the patient if the patient really is having that SpO2, especially on exertion. Of course, remember that a refractory hypoxia, really, this is an indication of admission. It's a refractory hypoxia, so it's inadequate arterial oxygenation despite an optimal level of inspired oxygen. Also, this is a condition of admission. Next slide, please. Okay, so the COVID-19, this was really, it was a pandemic which has lasted extreme stress or in health care system. So obstetric care providers that are managing pregnant patients with COVID-19, of course, in our case, it's in all hospitals from DH to referral hospital. And in those settings, where really they are a little to not experience it, to develop protocol and the guidance. So really it means really in our settings when this COVID-19 came in, really we didn't have any material, any protocol, any experience on COVID, any whatever on COVID guidance. So actually, if a pregnant patient with COVID-19, really, we should consider the oxygen supplemental is required and needed to maintain appropriate SpO2 level. Of course, we need to follow or trend in oxygen supplementation and the work of breath, especially the respiratory rate, which is above 30 beats per minute, really, to maintain adequate oxygen saturation. And the sign of worsening disease and the signal really a need for a higher level of support and care. So really don't delay on the patient who is pregnant and present to you with respiratory distress. Please remember to put the patient on oxygen, and especially if the respiratory rate is above 30, please put the patient on oxygen and initiate supportive care therapy. Next slide, please. Okay, so 75% of positive mother are asymptomatic, and only 25% are asymptomatic. Really, this is how a maternal distress in COVID-19 really it's a concern in our settings. So can't imagine how we have a symptomatic rate at 75%, and the pregnant women are at increased risk of severe disease if you compare to other generations, not pregnant people. And those pregnant women are highly likely to be admitted in the ICU, and their cause especially will end up on ventilator support, which really will lead to maternal death. So this, how to say that the COVID-19 really it's a serious condition during pregnancy. Next slide to see the timing of intubation of a pregnant woman. Really, this time is individualized and will depend on patient maternal status, pre-existing comorbidities, diabetes, hypertension, and whatever. Of course, presence of multi-organ failure. And if the patient really requires oxygen supplementation, or the patient needs transport to other facility from health center to DH to referral. So really consider the intubation really is a crucial intervention where you may pay attention considering all those conditions we listed. Of course, intubation, when oxygen requirements maintained to maintain an SpO2 above 95%, and when the greater than 15 liters per minute, when patient is using a common nasal cannula or a mask, or SpO2 greater or we're giving oxygen between 40 to 50 liters by minute using a high flow nasal cannula. I know we have many high flow device in the DH, as long as they are provided by RBC. And of course, when you are above 60% by FiO2 by venturi mask, really don't hesitate to intubate. Those are really a criteria for exclusion. Don't let to intubate if you have one of those three conditions. Of course, consider early intubation really earlier than for an equivalent to normal pregnancy constellation. For example, increased airway edema, aspiration risk in pregnancy, limited functional residual capacity, as Madame Liberata previously was saying on those change during a pregnancy. So let's go on the next slide, where we see really what are the danger sign of this respiratory distress, which may lead to respiratory failure, then intubation, even if poorly managed or further complication, it will lead to a maternal death. So normally in non-pregnant people with COVID-19, the danger signs are difficult breathing or short of breath, hypoxia, which is being manifested by bluish extremities, or gasping when speaking, coughing up blood, is hemoptysis, of course, chest pain on coughing, dizziness when standing, altered mental status or severe stiffness, of course, inability to eat or work or drink. And then when we consider a pregnant woman in the case of obstetric conditions, so those danger signs are labor pains. So rupture of membrane, vaginal bleeding, decreased fetal movement, severe headache, visual change, seizures, or persistent fever, or unexplained really abdominal pain. So then after seeing the so dangerous signs, so let's see really the sign of fetal distress. Next slide, please. Oh, so usually we say the fetal is in distress when the baby is not receiving enough oxygen through the placenta, and then those sign the sign of that distress. So it may be from inadequate fetal oxygenation or breathing in amniotic fluid containing meconium. So then the clinical presence. So especially the change of fetal distress. So of course you may lose fetal movement. Of course, the growth in utero growth may be impaired. Of course, especially this heart rate, and the presence of meconium stained fluid. So, and remember, in our settings, really, we are not really measuring fetal growth. It's not a routine. It's not a routine for pregnant woman follow-up. But really, every pregnant woman we are checking for fetal heart rate and fetal movement. And then if there is fluid leakage, we're asking the presence of meconium stained the fluid. So of course, we are detecting those fetal heart rate by using a cardiotocography. This is CTG. So really, I know some hospitals are having this machine, CTG, others not. But really, in our training, I know this is not a new term for everyone here. This is CTG machine. So this machine, it helps to measure the change in the fetal cardiac response to declining oxygen, and it will record both fetal heart rate, which is called cardio, and the maternal uterine contraction, TOCO. Then we call it cardiotocography. It means we are measuring the fetal heart rate and the contractions at the same time. And then the fetal heart rate deceleration on CTG will represent a danger to the fetus and to delivery. It means the deceleration, we will go in the details from the next slide. Next, please. So let's talk more about the CTG machine, and call it a principle of CTG monitoring and systematic approach to analyze the CTG. So this is a combination of several abnormalities can increase the likelihood of fetal distress, and the suspicious of abnormal features, including baseline fetal heart rate. So the normal fetal heart rate are between 110 to 160 beats per minute. So at this baseline fetal heart rate outside the normal range. So really, they are according abnormal features. So, and then it It may be bradycardia when it's below 110, and tachycardia when it's above 160. Then we will talk about baseline variability. So especially when those fetal heart rate are decreasing below 5 beats per minute. And then you can see reduced or absent acceleration, even the presence of deceleration. So let's take the next slide to start by baseline fetal heart rate. So the baseline fetal heart rate, the normal baseline fetal heart rate I said before, it's 1 to 10 to 160 beats per minute. And the fetal baseline bradycardia, it's when we are below 110 beats per minute. And those are those cause maybe kind of cold compression, acute fetal hypoxia, when the postpartum pregnancy, or those congenital heart disease. So also may have fetal tachycardia. It means we are above 160 beats per minute. So here you will see excessive fetal movement. When the fetus is moving, it means working. And you know everyone, when you are working, moving, our heart rate is increasing. It's the same to the fetus. So you might have excessive uterine stimulation. Because of course, when you stimulate the uterus already, you stimulate the baby. Of course, you get tachycardia. Of course, the maternal stress or anxiety, maternal pyrexia, this is the fever. Of course, fetal infection, intrauterine, and the chronic hypoxia. Of course, prematurity will present with this tachycardia above 160. So next slide. Next slide to see those variability of fetal heart rate. So this, when we say fetal heart rate variability, it refers to the normal beat to beat change in fetal heart rate, and is between 5 to 15. And this fetal heart rate variability, the normal, as I said, is 5 to 15. And when it's above 15, we say the fetal heart rate variability is increased. When it's below 5, we say the fetal heart rate are decreased. So when it's below 2, really, we say fetal heart rate variability is absent. There's no variability. So in the case of fetal hypoxia, so we have absent or decreased variability. So it means in the case of fetal hypoxia, you can see all of those variability, and it will depend on the fetal response. So in the case of decreased variability, so it means this fetal heart rate will be below 5 beats per minute compared to the baseline. And the fetus may be really normal or sleep awake pattern, means sleeping, short time, then awakening, sleeping, awakening. Yeah. Also, in the case of prematurity, can see the decreased variability. Of course, some drugs, especially opioid, which might help the fetus to be more sleepy, and they measure the decreased variability, which is below 5 beats per minute. So let's go next slide. Talk about acceleration. Okay. So when we say acceleration, you say more or periodic transient increase in fetal heart rate, and compared to the baseline. So an increase in the fetal heart rate above 15 beats per minute for more than 15 seconds. So it means you come to a patient or on your CTG, you see for example, you see fetal heart rate is 130. And you see on your CTG, after 15 minutes, it becomes from 130 is above 145. Just call that acceleration. That's, I think, with this area you understand more. And this associated with fetal activity. Especially, it means you put a CTG, you record, and your fetus start to move. A day, the fetal heart rate directing 15 minutes. This is a short time, and the fetal heart rate really increase by 15. So then, really, if you see those acceleration, make sure your fetus is healthy. It means it's moving. It's moving. So let's take the next slide and talk about deceleration. So deceleration, those are periodic transient decrease in fetal heart rate. And they are associated with especially uterine contraction. It means when the uterine is contracted, really the fetus kind of it's distressed. It's distressed and it's no longer able to move. Because and those the deceleration we divide in a subgroup and formative by shape and timings. So this will be seen on the CTG. We see early deceleration, late deceleration, variable deceleration, or prolonged deceleration, or bradycardia. So, and remember, this deceleration will be when they from below 5 beats beat per minute, you start to say those deceleration. So let's talk on the early deceleration or the next slide to see what is early deceleration. So when we say early deceleration, we say that those fetal heart rate which don't fall by more than 40 beats per minute. Here we're still on CTG, and those are caused by compression of the fetal head during contraction, where you see those deceleration. During the contraction, the fetal head is compressed, and those fetal rate will fall, but not more than 40. So of course, those are relieved by changing maternal posture or position. Of course, there are normal findings in the second stage of labor. So I think everyone here has really know what the second stage of labor. Of course, those early deceleration are not associated with a poor fetal outcome. Let's go on the next to see late deceleration. So those late deceleration, they are uniform in shape on the CTG paper. And they start after the peak of the uterine contraction. It means when the contraction start, you start those shape will be uniform everywhere. And they're called late deceleration. And they are associated with a decrease in the variability of the fetal heart rate and decreased uterine blood flow. So, in case of contraction, the blood flow is kind of obstructed and it's not really moving, it's decreased. And those fetal heart rate will be like deceleration. So those are many causes: hypoxia, placenta ablation, cord compression, or prolapse, or excessive uterine activity, maternal hypotension, especially in case of hypovolemia. So, though when you say variable deceleration, next slide. Next slide. So when we say variable deceleration, come back. Okay. So both variable in timing and size. So it means in case of variable deceleration, really those they will be accompanied by increased variability of the fetal heart rate, especially when the umbilical cord is compressed, and this will reflect a fetal hypoxia. So next slide. So when we say bradycardia, fetal bradycardia, or prolonged deceleration, so those will be a reduction in fetal heart rate more than 30 beats per minute that lasts for at least 2 minutes. It means that this a decrease of fetal rate in 2 minutes, and it may be caused by a decrease in oxygen transfer to the fetus due to a wide variety of disorders, maternal hypotension, or cord compression, or uterine hypotonia. And those are the bradycardia, which are the most common in that condition. So let's go to the next slide to see really how to analyze and categorize on our CTG. So if at your hospital you have a CTG machine, maybe you might have also this chart. So this chart just is helping you to see, to plot. You plot your findings from CTG on this chart, then you later you will get, you will compare, you take, of course, a decision. So when we told before, the baseline fetal heart rate, when they are reassuring, that means they are normal. It's between 110 to 160. And when on your CTG, they are not reassuring fetal heart rate, so it means that they are below of 100, between 100 and 110, 9. Or when at tachycardia, 161 to 180. So really I say I have a non-reassuring fetal heart rate. So it means you will need more time for checking those fetal heart rate to see if really you are sure. Of course, non-reassuring means you are not sure. When the abnormal fetal heart rate, so really when it's below 100, or when it's above 100, you know, this fetal distress. You hear you don't have any choice, any abnormal fetal heart rate, just, you know, you go in the theater for C-section. Otherwise, you got more in utero. So when you say about variability, we say about really when you are having, if your fetal heart rate are changing really 5 beats per minute or more, really make sure those are normal. It means you can come now, take a fetal heart rate after 5 minutes, or you come back, your fetal heart rate, they are more than 5. Really, this is not a big range. That's it's normal. They are showing variability. So, but is it below 5 for 40 minutes or more, but below 90 in a minute? So really, because that is not, it's really not reassuring to be the same action in a patient. And they are abnormal where they are below 5 for 90 minutes or more. Really, this is a big time. 1 hour and a half. This is a big time. When they are really below 5, consider they are abnormal. And so when you have, in the case of reassuring, it means normal fetus, really you will see acceleration. So remember, we say acceleration, it will assure you that the fetus is moving, it's healthy. It means really in normal pregnancy, those acceleration really will make sure the fetus is moving. This means those fetal movement. So then in the case of non-reassuring fetal heart rate, really there's no, you can't find acceleration. It means acceleration stands for a healthy fetus. So, and then deceleration, it means the fetal heart rate are decreasing. Deceleration can't be reassuring. If you see fetal heart rate are decreasing, in time, consider there is a problem. And then here, because of non-reassuring, you said early, variable, prolonged, or deceleration, talked about it. So in the case of abnormal, atypical, variable, late, or prolonged more than 3 minutes, that consider your fetus is having a problem. Just don't delay in your decision making. So in the case of reassuring, we say that's a normal ECG. normal CTG, sorry. And in the case of non-reassuring, really consider a suspicious CTG. Really here you can call it normal, abnormal. Then here you need more time to be sure of what you're doing, even the close monitoring. And then if you see any abnormal fetal rate, any abnormal variability, and you see acceleration, you see there's no acceleration, you see the deceleration, that's a pathological CTG. And then later on, please don't say normal CTG if we had one of those abnormal criteria. And then at the end, you will comment your action on this line below. Say maybe go to the theater, maybe call a senior, transfer the patient, then you stamp with everything and your signature on your CTG. So that's all on maternal fetal distress. And then let's go on the next slide. To update our patient. So remember, our patient came in with short of breath, and then later on you saw he was in respiratory distress. So and then at the end of our patient file said the patient was diagnosed with acute respiratory distress syndrome from presumed COVID-19. So now it's become really a serious condition. So our patient later on was put on the lung protective ventilation settings or the mechanical ventilation. The maternal fetal medicine specialists are following the clinical status of the patient and fetus. So our patient now is in the ICU for mechanical ventilator support. So really now, what is the next? So let's continue to see how to manage a critically ill pregnant patient. So next slide, and we invited Dr. Venus, I think is around, really to update us on a multidisciplinary team really approach. Which team is required to manage a critically ill pregnant patient? Dr. Venus, welcome on the panel.
Thank you very much, Dr. Joseph, for the nice talk. And thanks to everyone in the attendance. So I'm going to continue with the multidisciplinary team that is involved in the management of a pregnant woman who is critically sick. So to address this, we have first to appreciate the difference that can be made by the human resources, like a case of Western world versus our context. So we have 4 different levels of care that are standardized to try to address the morbidity, mortality for the pregnant women, but also to improve the fetal outcomes. I don't know if everyone is hearing me well. Do you hear me clearly?
Yes, we are hearing you very well.
Okay, nice. So next slide. Yes, first of all, my apologies for the characters that may be appearing small or full. I didn't see any better way of expressing this. So let's see what can be done from level 1, level 2, level 3 to level 4, where critically pregnant women can be taken care of. In level 1, for instance, it's a certified birth center where you can take care of low-risk women with uncomplicated, like monofetal term pregnancies who are expected to have uncomplicated birth. So the personnel or the staff unit at this level you need at least one qualified birth professional, like a midwife or a family physician or OBGYN, who is trained and a qualified registered nurse who has appropriate competencies. So you have you need like a physician who has the competencies to do emergency cesarean section. And you need primary maternal care providers like midwife, family physicians, OBGYNs that are readily available at all times. If you compare the context, the Rwandan context, like in the health post or health centers, you don't have anyone who Hello?
We are hearing you.
Can you say, go ahead.
Yes. I'm saying in level 1, at least you need a team that can perform emergency cesarean section. In contrast to what we see in a Rwandan context, where like a health center, which is a certified birth center, which can do spontaneous vaginal deliveries. In Western world, in level 1 birth center, you need a team that can at least do cesarean section, and you need someone who can do at least a limited obstetrical ultrasound. But also you need nursing leadership, you need anesthesia providers like anesthesiologists, nurse anesthetics, anesthesiologist assistants. Those ones we don't have local, like the assistant anesthesiologist. So you see in Western world, in level 1 birth centers, they have enough staff which can intervene to prevent the mortality, morbidity, and improve the fetal outcome. Next slide. So level 2 birth centers, it's kind of specialized care which is offered there, and you need level 1 plus care of appropriate moderate to high risk antepartum, intrapartum, but also postpartum conditions. Among the personnel you need in level 2, you need an OBGYN readily available at all times, 24 hours a day, 7 days a week. You need this obstetrician and gynecologist who can help this pregnant woman. So you also need physician with obstetrical leadership who are both certified with OBGYN experience in obstetrical care. You need also a maternal fetal medicine specialist who are going to help for consultation on site or by phone or through telemedicine. You also need anesthesiologists who are available at all times. So you also need internal medicine or family physicians, general surgeons readily available at all times for obstetrical patients. You can see how tough to have these human resources locally in our context is very difficult, but you can also appreciate the differences that this staff can make when they are facing pregnant women who really needs help. Among the capabilities available at this level 2 birth centers or specialized care, they can have access to CT scans, MRI, or obstetrical ultrasound as well. let's see what we can expect in a standard level 3 birth center. Next slide. So in level 3, it's kind of subspecialty care which is offered there, and you need level 2 facility plus care of more complex maternal medical conditions, obstetrical complications, but also fetal conditions. Examples here are like pregnant women who have like cardiac disease or cardiomyopathies, or those with valvular heart diseases, or those with uncontrolled, let's say, hypertension or preeclampsia with severe features. So in this level 3, you need level 2 staff, plus also nursing leaders with adequate registered nurses who have special trainings and experience in managing women with complex but also critical maternal illnesses and obstetrical complications. You also need board certified OBGYN that are physically present at all times. And you also need maternal fetal medicine specialists with privileges readily available at all times, either on site or through phone intervention or telemedicine. So you also need a director of fetal maternal medicine, a director of obstetrical service, both certified anesthesiologists present at all time. You also need a full, complete complement of subspecialties like specialists in critical care, general surgery, infectious disease, hematologist, cardiologist, nephrologist, and so on. You can see how tough, again, to offer this subspecialty care is very difficult in limited resource settings. Next slide. So level 4, which is a regional perinatal healthcare center, you need level 3 services or personnel plus on-site medical and surgical care of the most complex maternal conditions, critically ill pregnant women or fetus throughout antepartum, intrapartum, but also postpartum care. Examples here are like our patient who is having ARDS from presumed COVID-19, who is requiring mechanical ventilation. So, but other examples here, you have like a patient, a pregnant woman who is having pulmonary hypertension, for instance, or advanced cardiac condition. Those ones, they really need regional perinatal health center care centers to have better outcomes. So among the staff you need those at the level 3 plus maternal fetal medicine care team with expertise to manage high complex, critically ill and stable or maternal patients. You need people who are specialized in ICU care, nursing service line leadership with advanced degree and national certification. You also need continuous availability of adequate numbers of registered nurses who have experience in the care of women with complex medical illnesses, but also obstetrical complications that are going to work in collaboration with critical care nurses, obstetrical nurses who have expertise in caring for critically ill women. You also need a certified anesthesiologist with obstetric anesthesia fellowship training or experience in obstetric anesthesia that are going to be present at all times. other subspecialties we have seen previously, like cardiac surgery, neurosurgery, transplant team, all of those, they need to be present in these regional prenatal healthcare centers. Again, think about places where the resources are limited in terms of human resources. So applying this might be very tough. Let's see on the next slide what we can take as a multidisciplinary team in Rwanda to take care of, like, let's say our patient who is having ARDS from COVID. On the next slide, please. Yes, in Rwandan context, where we don't have this maternal fetal medicine specialist, advanced like cardiac surgery. So our patient, pregnant woman who is critically sick, in Rwanda, the typical team might be represented by a general nurse, specialized in critical care, midwife, technician anesthetist, or nurse practicing anesthesia, anesthesiologist, as we don't have assistant anesthesiologist locally. You also need an OB/GYN specialist. You need the general surgeon, pediatrician, internist, and other specialized fields like nephrologist, neurologist in case needed, or neurosurgeons. But apart from the obstetricians, anesthesiologists, the technical technician anesthesists, the other staff, they are usually intervening when they are called during constant calls. So you cannot have them readily available in the maternity ward or the labor ward or the, what can I say, the maternity HDU, if I can say. So it's not easy to achieve these standardized levels of care in Rwanda, but it's a progress. Next slide, please. So after seeing the multidisciplinary team to take care of a severely sick pregnant woman, let's see the unique considerations during the resuscitation of a pregnant woman, because the progression may be worse and they need to be resuscitated. If you are resuscitating a pregnant woman, you have to take into consideration that you are dealing with two patients, the mother and the fetus, at the same time. So a consideration of post-mortem cesarean section needs to be considered initially. So when you are at the scene and a pregnant woman arrest, you notify the maternal cardiac arrest team. Then you can document the onset of maternal cardiac arrest. You place your pregnant woman in the spine position. Then you start the CPR according to the basic life support. And when the other staff come to intervene, you continue the BLS, ACLS protocols. And you have to consider that one intervention which is going to help you have a good outcome is to ensure there is this auto cover decompression that we have seen in the physiology of pregnant women. So any uterus that is reaching the umbilicus, it's enough to compress the inferior vena cava, and it can compromise the venous return, the cardiac output, and during your resuscitation, if this outer cover decompression is not done well, you are unlikely to have success. So this decompression is done by left uterine displacement done manually. Initially, in the past, people were using left lateral tilt, and this left lateral tilt was not allowing the patient to remain spine, and doing a CPR was not successful because the patient is not in the spine position, and somehow you are not accessing the airways, and pressing the IV lines might be difficult if the patient is in the left lateral tilt. But with this manual left uterine displacement, as we will see in the next slide, it allows the better positioning of the patient, but also improving the venous return. Another significant issue to consider in resuscitating a pregnant woman is to consider this physiological changes happening to pregnant women regarding airways, breathing, but also circulation. So on airways, the modifications you need to make for pregnant women, you have to consider them as having difficult airways. Always, this is a must, because even in non-arrested pregnant women who are requiring general anesthesia, failure of intubation incidence is around 1 in 300 at intubations. So you see how significant it can be in the clinical practice. So you consider using the most skilled personnel to manage the airways, and in centers where you have the video assisted intubation, they are better than blind intubation. So you also need to consider a small endotracheal tube to be successful in this intubation. Let's see on the next slide what we need to take care for the breathing. So for the breathing, pregnant women are at increased risk of rapid desaturation due to reduced oxygen reserve, and this reduced oxygen reserve is a result of high oxygen consumption plus reduced functional residual capacity. So you need to pre-oxygenate when you are trying to intubate the pregnant women. And you have to consider in mind that you may have uterine vasoconstriction leading to fetal hypoxemia that can occur with maternal respiratory alkalosis. And this respiratory alkalosis, we have seen how it is common in the session of physiological changes during pregnancy. So there is also a risk of aspiration during maternal cardiac arrest due to reduced lower esophageal. Difficult to control airways if they aspirate the gastric content. Next slide, please. So on the circulation aspect, and which is almost the most important thing to consider if you are attempting to bring back the circulation, is to ensure there is this autocover decompression. This autocover is caused by a gravidic uterus, and we have seen the gravidic uterus enough to cause this compression is when it reaches the umbilicus level, even from 12 weeks of gestational age, it's enough to cause compression. But as the gravidic uterus increases in size, the compression also increases. So this manual left uterine decompression is going to allow you to have successful chest compressions, airway access, access to the IV lines if you want to place an IV line during resuscitation. So it because you will not be able to manage the airways to access to do effective chest compressions. Next slide, please. As we are dealing with very sick patients, which is a state where the healthcare providers are under stress, you need to use cognitive aids, which are the structured information cognition adherence to best medical practices. These cognitive aids are in the forms of either checklists or posters, flowcharts, or even mnemonics. They help you gain time because you are not using a lot of memory to recall what to do, but also it will facilitate you to make decisions in a timely fashion, and it will overall reduce the burnout during these emergencies. So let's see some examples of cognitive aids for obstetrical emergencies. Next slide, please. So this is it's an emergency manual cognitive aids. It gives some tips you can use either if you are managing or evaluating or assessing a patient, a pregnant woman who is either having a cardiac arrest or any obstetrical emergency. Next slide, please. So taking an example of pregnant woman who has no pass or who has a collapse. So what you need to do immediately, you need to, this cognitive aids tells you that you need to position the patient in the spine with the backboard under the patient and perform this manual left uterine displacement and do chest compressions. So the chest compressions follows the usual basic life support. You only need to be slightly higher than usual on the sternum if you are going to place. And you try to avoid the fundus of the uterus. So then you attach the automated external defibrillator and assess the rhythm. If it is shockable, you give the shock. Then consider airways, definitive airways management by pressing endotracheal tube, ventilating, after confirming correct placement of the ETT tube. And you need to give 10 breaths per minute with 100% oxygen. So it also reminds you to have a IV access using a 2 large bore IV, preferably 16G above the diaphragm. So you may as well use intraosseous access if you fail to gain the IV access. So it also requires you to consider perimortem cesarean section after, and this is considered at the 4th minute if you don't recover or bring back the circulation. You have to consider doing this cesarean section, and they call you again when at the time of the arrest. It's the time to prepare for the possibility of this cesarean section requirement, and you alert the NICU team. You perform. If no return of circulation, you perform the cesarean section. So you see how useful these cognitive aids can be of importance in the emergency. If you are dealing with emergencies, obstetrical emergencies during the intrapartum or postpartum, anytime. So you can give yourself a task of designing what you think is going to help you in the department, in the labor ward, or wherever you think you're going to deal with obstetrical emergencies. So this is another cognitive tool to help you assess the possibility or the causes of maternal cardiac arrest. So ranging from anesthetic complications, embolic causes, causes related to fever or going with fever, bleeding, causes related to cardiovascular disease, drugs, hypertension. So you can do a check, you can do cross-check to see what might be the cause of the cardiac arrest for your patient, and it helps you gain time and provide necessary investigation or interventions to try to help your patient. Next slide, please. Then as we are having our patient who is having COVID-19 acute respiratory distress syndrome, we need to have evidence-based information to guide us to help pregnant women who are having COVID-19. So the resources for the protocols, you can have them either from this covidprotocol.org, or you can check on American College of Obstetricians and Gynecologists, Society for Maternal Fetal Medicine, WHO guidelines on maternal health. I think the technical team is going to share these links, and you can copy them and use them when you need to double check on what can be done to a pregnant woman who is having COVID-19. Next slide. So before I conclude my presentation, I want to highlight some key considerations to take when you are dealing with a pregnant patient who has COVID-19. So you have to keep in mind that the risk of severe coronavirus disease during pregnancy, it is even higher than in the general population. So we have seen it with the presentation of Dr. Joseph, and bear in mind that the risk factors for severe COVID-19 are similar in pregnant women to general population. Here we mean pregnant women who has underlying comorbidities like asthma, like uncontrolled hypertension, or heart failure, or cardiomyopathies, valvulopathies, or any uncontrolled medical conditions. It can press pregnant women to have a severe form of COVID-19. So you have also to consider that the vertical transmission for COVID-19 is possible, even if the mechanisms are unclear. And the good news is that severe neonatal disease is rare for COVID-19. So the antenatal corticosteroids used for treating preterm birth is likely to be safe for mother. And corticosteroids used for severe maternal disease may be beneficial. This is critical when you receive a pregnant woman who is having COVID-19. Don't miss giving these corticosteroids. They are safe and they may help the maturation of the lungs for the fetus to prevent or to try to prevent the respiratory distress syndrome of prematurity. So generally they are safe. So clinician also should have a overall threshold to start thromboprophylaxis in a COVID patient pregnant mothers. And the threshold for investigation for thromboembolic event should be very low. So you have to suspect the DVTs and pulmonary embolism, consider them high in COVID pregnant women. So in mothers with COVID-19, they should keep breastfeeding. It's not a contraindication. You only need to tell them to keep personal protective equipment, the facial mask. But as long as they are able to breastfeed, they have to keep breastfeeding. So asymptomatic COVID-19 is common in pregnant women, as we have seen in the previous presentation, around 75%. So you also have to keep in mind that the COVID-19 in pregnant women can have wider implications, and you have to take pregnant women with COVID-19 to be screened for any mental health distress and any intimate partner virus, because they may be possible and hinder the outcome for both the mother and the baby. So this is the list, but not the last but not the least slide for today's talk. We can give time to the audience for questions before Joseph gives the take-home message. Thank you very much to everyone.
So thank you, Dr. Venuste, for your interesting talk presentations. So if someone from the audience is having any question or suggestion or add, so he might raise hand, or he might write in the chat to the left side, and then we can discuss more. So anyone is having a comment? Question, comment, the chat, and then you can use whatever language you want, Kinyarwanda, English, French, Swahili, whatever, and then we translate then, so to get a common understanding. So if no one, let's take the take-home message on the next slide, please. Next. Okay, one mahalo mate to everyone. Saying understandable. Thank you to Amaholo for things that the presentation was understandable. So then keep updating us in the chat line, then you can get question or suggestions. So as a key topic, leave you and take a message. It is so while we're managing a pregnant patient every time we are well. So really remember there is some physiologic change. Of course, remember that those physiologic change, they can affect the fetus and the maternal well-being. Of course, those changes, they will affect the clinical presentation of your patient, of course. So, of course, remember the bedside lab investigation, especially ABG. Remember that what Liberato was saying, really, this ABG, the normal limit in pregnancy are different from non-pregnant people. So, of course, remember the goal of the oxygen therapy in the pregnancy, and you recognize the sign of fetal and maternal distress. So, as Venus said before, of course, remember that you need a multidisciplinary team. Really is really required for optimal care of the critically ill pregnant patient. And every time, if they remember and the unique constellation during the resuscitation, as Felisa said before, really you are dealing with two patients. Don't consider the man or the fetus, just you have the two patients. Of course, you need to recognize and to use those cognitive aid for obstetrical emergency. Of course, really, you need to be able to assess and use the COVID protocol in your settings. So really, thank you again for our audience. So here I see that we have two comments. Jean Felix saying, I'm getting two. Oh, thank you, Jean Felix. So really thank one all attendee for this presentation. It was obstetric constellation. Also, let's thank again our partner. As we said initially, Stanford Anesthesia Division of Global Health Equity, Assist International, and the Project ECO. So really, if you have a question or a suggestion, you have our emails. You can email us on our email, then you get clarification. Of course, this presentation data will be shared to your emails. I have it, and then we continue to be updated. So thank you everyone for participation, and then also really let's thank the IT team. Really, now the display was really more clear if you compare to the last one. Of course, remember in Rwanda you are in heavy raining, that really it's difficult to get and connection, but today really it was very clear. Display was very easy. So thank you to everyone, and then let's give back the word for the last comment to the team for closing. Thank you. Alana?
Yes, thank you so much, Dr. Joseph. Echo India, feel free to end the meeting, and we hope to see everyone again in 2 weeks.
So thank you.
Thank you.